Good morning and welcome back to DNP 520. I do have Terry with me.
Hi.
So we hope that you have gotten to listen to some of our lectures. We know that you guys are currently still studying probably and getting ready to take quiz number 1. So we don't want to overwhelm you guys, but we're going to continue to record lectures. So the modules are up for you guys when you can get to them. So today we're going to be talking about gynecological cancers. So vulvar cancers is kind of one of the first things on our list, usually related to HPV or vulvar intraepithelial neoplasia. Yeah, here I go.
With the prevalence of HPV, you're going to see different things that come on the vulva when you're doing your exam, and you'll see the regular nevus like you would see anywhere else on the body. But if there's any suspicion, color change, itching, bleeding, or just plain old doesn't look right, it's a good thing to biopsy, because you could be quite surprised with what you could find. So
when it says lump or mass, right? So
yeah,
would you see something that kind of looks suspicious?
So
obvious?
It may not be that obvious. So you really have to be careful in your initial exam of the vulva. So take your time whenever you do go through your exam. Take your time on the outside to spread the vulva out so that you can see all of the aspects of each side, and even down toward the anus. I have found it looked like a tiny wart, and I actually missed it the first time until the patient pointed it out. What do you think about that? I feel something there. And so I took a closer look, and I said, yes, we're going to biopsy this. So I had her come back, and it was not right on the anus, but it was far enough away where I could safely biopsy, and it come back as neoplastic. So,
wow.
And so at that point, based on where that particular lesion was so close to the anus, I sent her to a surgeon. And then she didn't like what the surgeon said.
Oh my goodness.
So we went even further with a gynecology oncologist.
Wow.
Yeah. And I mean, he was willing to see her at this point in time, but it was a very small, that's why I missed it. It was so small. It wasn't sticking out there. So yeah, you need to do a thorough exam.
It's kind of just the same as breast, right? I mean,
exactly,
we really need to be taking care, and it's hard to see down there. And some people put mirrors down there and really do a visual exam.
And even if you did, and even a thin woman has a hard time with lighting and to see everything. So they depend on me to be able to get that thorough exam. So it is important that you take your time with that exam so that you can evaluate. And if there's something that you don't know has been there before, or and sometimes you can say, what about this mole here? Oh, I've had that forever. Any changes in it? Does it ever itch? Does it ever bleed? Does it ever get irritated amongst your clothes? No, I'm fine with it. And then you're pretty well. They've had a long time. You know, it's just an ordinary mole. But anytime you question that, is that something I should be concerned about? Go ahead and biopsy.
Why not?
Yeah.
Better safe than sorry.
Exactly.
So there you go. You just said it. Vulvar bleeding, discharge, dysuria, or pain. So some of the things that, we can look for, that's kind of the abnormal things that shouldn't be happening or taking place down below, right?
Exactly.
So annual pelvic examinations for all women 21 years and older. And I think you brought up such a great point to make sure you're doing a thorough visualization down there. That's what my preceptor always used to say. Make sure before you stick that speculum in that you're really looking. Things could be missed. So biopsy required for definitive diagnosis. You just talked about that. And then of course we stage by that classification system that we all know.
Well, and if you do find any kind of neoplasia, you need to refer. Now I have learned through my own practice that VIM1 may be just a regular gynecology, that they could do that. Depends on where it is and how involved it is. But if it's 2, 3, or 4, you need to refer out to a gynecology oncologist at that point.
Absolutely, absolutely. So avoid exposure to HPV. Unfortunately, that's, how do you really know,
Yeah,
right? I mean,
exactly.
that
Until it's
that
already
looks great, right?
happened.
Vaccination, we kind of already spoke about, I'm pretty sure, during our STI lecture. So we're good there. Seek treatment for vulvar itching. What's your thoughts about any of these things?
Well, can I say something here? It says no smoking because we know the
Yes,
relationship
yes.
between, and we'll go back a little bit.
No,
Or
please
is that
do.
the same one?
Same. Yeah.
Smoking and HPV go hand in hand and increasing the risk of either cervical cancer or even vulvar cancer related to HPV diseases. So that's important. The routine vulvar self-examination, that's hard for a lot of women now that our society is either overweight or obese. Women cannot see down there whenever they have so much fluff that they can't find their parts. So I can't express enough of whenever you're doing, even in the family practice, if you don't go into gynecology, your family practice, take time to look thoroughly because they can't.
Absolutely. All right.
And what was your question?
So that was kind of it. So it's the surgical resection is the standard treatment. So yeah, so trying to get it out. Counseling for grief, well, that's just for cancer, chemotherapy for medicine.
Well, you asked me about itching.
Oh,
yes.
Yeah.
So it's worth seeing if you can get that treated. So if you have, depends on if there's a lesion, if there's some erythema, if it's
yeasty, right?
Yeah, whatever. And so go ahead and test for vaginitis and of the vulva. Rule that out. But say that's negative and they're still itching. One thing you could try is just a low dose of a steroid ointment or steroid cream, but bring them back. Did it help? Did it go away? And if it didn't, that's when you need to biopsy.
Right.
If you cannot get that controlled.
Right. That's such a good point. So make sure you're looking at your differentials. And then if you can't treat whatever's going on that you want to seek, you need to be proactive in these patients for sure. All right. So cervical cancer, 4th most common genital malignancy in women. If it's detected earlier, they have a better survival rate, of course.
So
there's HPV again.
Yep, the HPV. And so, there's different ways of screening, and we have standards of care. The ASCCP is the gold standard. That's the one that I use, and I think most of the providers use in the office I work at. So there's actually an app from that particular group. Yeah, but it's worth that $10.
Is it?
It's a one-time fee of $10. I keep it on my phone and I pull it up to be able to
see what I'm doing. I'm getting my phone.
So this is my app here.
Okay.
Yep. And so I use this daily.
Wow.
Even though a lot of this comes quickly to me, I still look to make sure that I'm managing these abnormal paps like I should, because you would be amazed at the number of referrals that I get in that are referred wrong.
Really?
Yeah. And so this is what I pull up here. And so you can actually put her age.
Y'all look, and if you, I don't know if
they can see it.
I don't know that I can get it.
But they can pull up ASCCP. It stands for American Society of Colposcopy and Cervical.
It does.
And so they, like I say, they set the gold standards. They're based on teaching colposcopies, how to treat, and they give us our guidelines. So this is an easy app to use to pull up. You can put the age in. What the pap smear shows is the status of the HPV and if they're pregnant or not, and what the cytology results are. And then you can pull next, and it tells you exactly the algorithm that you need to follow.
That's
So this is a
incredible.
great resource.
That's
to
where it's at,
use.
guys.
Yeah.
ASCCP app.
Yes.
$9.99. She
Yeah.
says it's well worth it.
Yeah, I think I paid that 5 years ago, and it hasn't gone up. So it doesn't charge you every year. So it's up to
Flat
date
fee.
information.
That's
Yep.
that's
yeah.
awesome.
So,
Phenomenal.
Anyway, that's our gold standard and how we manage our PAPs. And so when we have beginnings of cervical changes or even the presence of HPV, we don't let them go that 5 years, because it's not normal.
Right.
But my years of practice, we used to repap everybody every 3 months for abnormals, and we don't do that any longer. So what we've learned over the years, that HPV is usually slow and damaging, except some of the aggressive strains, and that's usually 16, 18, and 45. So when you have that, if there's certain, you can actually order that when you're doing a PAP, say on women 30 and older, and you want to do her screening PAP, you can not only do the cytology, but also add the HPV, so they can test for HPV. And you can specifically say not only those 14 high-risk strains, but are they positive for 16, 18, and 45? Because when they shows up, even the first year, you need to go ahead and do a colposcopy or refer.
Oh, there you
Yeah,
go.
yeah. So those are the most aggressive that they have identified so
16,
far.
18, and 45.
16, 18, and 45. And I've actually seen that on some tests. So I don't know y'all's certification tests, but on the ones I do, those are
there.
mhm.
Yeah, I'm pretty sure. Yep, I can understand that one too. So it's found in 99.7% of cervical malignancies. So we kind of know that.
Well, and one point I want to make with it, some of the referrals that I'm getting, I've had patients upset when I mention HPV because they may have had a abnormal PAP in their primary care office, and it says low-grade squamous cell intraepithelial lesion. That's what LSIL stands for. And that just means mild dysplasia in common terms. So when you have somebody 30 and older with mild dysplasia, they need a colposcopy for further biopsies. So that oftentimes they're referred to us. But there's no mention that they may not necessarily on that pap smear have a positive HPV. It's whatever the practitioner orders at that point. So, but there's the assumption that if they have mild dysplasia, they have changes on that cervix, it is HPV that's causing that.
Oh.
And people get very upset with me because by this time that they've seen their provider, they've been referred to our office. We show them a computer module that explains what I'm going to be doing and about HPV. They don't think that even affects them because their nurse practitioner didn't tell them that they had HPV. And when I'm telling them that's what it is, they're like, why wasn't that mentioned? So yes, almost 100% of the time with any kind of dysplasia, it is caused by HPV. Wow. Yeah. Wow. So make sure your patients understand that.
Some communication there.
Yeah, exactly.
So adenocarcinoma, 10 to 12%. So it's just kind of giving some statistics. Early age of first intercourse is a risk factor for HPV. So that's why, we really want to encourage people to get the vaccination, which we've kind of talked about. And there's that smoking again, some causes.
Well, and even with birth control pills, and we put, teenagers on birth control pills. And the reason that not only is the risky sexual behavior, you got them on pills and they're trying to keep them from getting pregnant, But what too is the pills will change the transformation zone, making that wider, that ectroping of the cervix, the surface of the cervix, the type of cells that are closer to the up inside the canal, it widens that. So it makes the surface of the cervix more susceptible to absorb HPV. So it's not that you shouldn't put your patients on birth control pills, but there is that risk. So condoms, you know, to help prevent. Gardasil, Gardasil, Gardasil. Yeah, you know, it's unfortunate when we don't have everybody vaccinated until they're older. So that's I wanted to explain that's why that is.
All right. And of course I can't advance it now. There we go.
Mhm.
All right. Abnormal vaginal bleeding is common. Abnormal discharge may be present. What do you normally see with these patients?
So whenever a woman comes in, she might not have had a PAP in a while. Usually, and then she may just be bleeding from something else, some other cause. We usually see abnormal vaginal bleeding whenever it's in the later stages of cervical cancer. And most of the time they've not been anywhere for years whenever it gets to that stage. So when you see a healthy, pink, smooth cervix, and they're reporting abnormal vaginal bleeding most of the time, that's not to that state yet now, because you can't look and see abnormal pathology or cytology on by just looking. But when it gets to be an abnormal appearing cervix, it's friable, that's when you need to suspect it. And if they haven't had a PAP and you're evaluating their bleeding, they haven't had a PAP in several years, that's whenever you should go ahead and PAP them.
Good point. And then of course there's the, you know, pelvic, abdominal, inguinal, lymph nodes, rectal exam, PAP test. There it is. Ruled out prior to diagnosing cancer, which is, you've already said all this. It's almost like she knows what is coming up next, because we said this, you would rule out all of these things before we sit there and say, okay, this is what we're dealing with.
Yeah.
There's our Gardasil. We've talked about that. Treatment of precancerous lesions and even the CIS, removed by cryosurgery, ablation, or the LEAP procedure.
So let me say something there.
Yeah.
So you heard me say colposcopy, and that's just a microscopic look of the cervix. And most GYNs can do that. Family practice refers to us for that. But once we get through the colposcopy, it's the treatment that they're referring to here. So treatment of precancerous, when you get to moderate, severe, or CIS, you know, it depends on what that cytology is going to be from your colposcopy before you make that decision. So if I've got somebody with CIS, carcinoma in situ, I'm not going to do a LEAP on her. I'm going to refer her to a surgeon to consider a cold knife cone. But the loop and the electrosurgical excision procedure, that's the same thing. It's what we were called refer to as a LEAP.
Yeah.
But cryosurgery, we don't do that anymore. It's very outdated. So they taught me in 2003, but that's when they also said that's not a good treatment. So I wanted to make sure the conization is the cold knife cone. That's what the surgeons refer to that. And that's just a deeper section of the cervix. And if you could look at it as a side view, it looks like an ice cream cone that's taken from the cervix and the cervical canal. So that's whenever you get into possible even early CIS, you want to make sure that excision goes down deep enough into the cervix. The cervical length is usually a couple of inches, but that's why it can, if you're real deep with this, you might miss a lesion.
Wow.
Yeah. So
wow. So lifelong surveillance at regular intervals, and you talked about bringing patients back, especially if you see something that's abnormal, and keeping a good watch on these patients.
Yeah. And they think because in some of the normal pap smears that you have, we can, with normal and negative HPV, and they've not had a history of abnormal, we repeat their PAPs in 5 years. That's for the 30 and older with normal negative HPV. And so they also think they don't need to come in for a pelvic exam in that length of time too. So it's important to educate them. You still need to come in for a pelvic exam. We may not do the pap smear every year. It just depends on what we find.
Right.
And of course, we're talking about abnormals now, so they need to be watched closer.
Absolutely. So carcinoma of the endometrium, most prevalent gynecological malignancy. So there's type 1, type 2.
So we see this, I see it pretty commonly, like it is the most prevalent. So I'm oftentimes doing endometrial biopsies to evaluate for that. So you're a woman who's 60 and older, who has carried a lot of weight over her lifetime, those women are more at risk for endometrial cancer. I think we've said this before.
Yeah.
So the exogenous or endogenous excess estrogen or the unopposed estrogen, you'll still see some women that come in and their provider gave them estrogen, but didn't protect the lining of their uterus with progesterone. I've had 2 recently in the past 6 months. Yeah, I don't know even why that's even being done, but somebody's just refilling it for them, and they come into me and I about have a heart attack whenever like I see that. Oh, where's the progestin? Where's the progesterone? What are you talking about? So it is a surprise. In those cases, they do need to have an endometrial biopsy and an ultrasound for further evaluation, even though they may not be having any kind of abnormal bleeding.
Wow.
So, and then there's a few types that are unrelated to estrogen. I do know of a young woman who, I think at the age of 40, who's always been thin and small, petite, that she had endometrial cancer. Not your norm, but you still need, you remember me saying, do an endometrial biopsy, even when they're 40 and older. That's something to consider at that point whenever you're evaluating abnormal bleeding.
All right, now I know we've actually talked about Lynch syndrome, so I'm going to let you have this for a second.
Okay.
You're big on some of this genetic stuff.
Well,
you found this a few times, right, with some of your patients?
Absolutely. So we've back in 2018, we started screening our women for possible genetic cause of breast, ovarian, colon, pancreatic cancer. And I think I gave Michelle a form that we use, and that's a very specific form, but it's our responsibility to go over this with your patient, that you can get specific details to see if they are qualified to have this genetic test done. And when we started this, we did, we were screening all of our physicals, our new patients' physicals, because we had not been previously screening most of the women. And part of the endometrial cancers are found on this, but Lynch syndrome has been quite a surprise to me. The gene that causes Lynch, I've probably had 6 women that tested positive for these, and it's floored me because I've found very few BRCA. BRCA1 or BRCA2, which is included in these tests. So we use Myriad, it's a national company, but that's just the company we've chose to work with. And the test that we do does include all of those cancers, and there's 2930 genes that are included in that, those that do qualify to have this test run. And so the gene that causes Lynch syndrome it pops up there. And that's more of the polypoid colon cancer. But it also includes uterine cancer on that, bladder cancer, and even in late instances, some women the breast cancer are a little more at risk with some of those. So it's very interesting, and I think this is the wave of the future, because American College of Obstetrics and Gynecology have recommended that we screen our women for early breast cancer detection, and that's when we started doing this genetic test. It's a little intimidating when we first started it, but the only other choices we had of screening our people, our women, would be to send them to Baptist or Asheville or Charlotte to a genetic counselor. And that was very intimidating. So we got very few women that were willing to do that. So we've really found some early cancers or genetics to prevent cancer. So we've identified some of these women. So it's exciting that we've found these women by doing
I
this.
think it's pretty cool, especially if you have a family history where this will actually let you do it and actually pay for it.
Yeah.
So,
Exactly.
but there it is, Lynch syndrome. So I did put this as a PDF for you guys to kind of maybe look at for your own knowledge of what's out there with genetic testing. And there's the Lynch syndrome right there, and what all that
And I think we're going to be seeing more and more of this particular problem, because it is so prevalent in the women that I see. So it's going to be important that y'all pick up on this in your day-to-day patient load.
So I love the fact that Terry can bring out new things that, you know, we don't just get in our textbook. Like I love that. And I appreciate what all she has to offer us as far as that goes. So all right. So risk factors.
Well, there it is.
Yep.
There it is. It's the
all
Lynch
there.
syndrome. Yeah. Estrogen therapy, and just make sure when you do have somebody that you're refilling their estrogen and maybe postmenopausal, that if they do have a uterus, that they need that progestin protection to prevent endometrial cancer. Tamoxifen. So more and more breast cancer and treatment, many women are treated after they have their initial treatment, they are prescribed tamoxifen, and usually that's a 5-year course. And with tamoxifen, it does prevent that, cancer from reoccurring. But what it does put them at risk for endometrial cancer. So many times, if I have a postmenopausal woman that comes in and she's been spotting, she's on tamoxifen, that's a red flag to me. I need to biopsy her, because she's at risk for endometrial cancer just with that treatment for breast cancer. So,
wow.
Yeah. I think this is early menarche, and then late menopause, they're at risk. But late menopause, okay, so most women by age 58, 59 have stopped their periods. I've had women to still bleed, very few in my career, but it's like, what's wrong? Because they are 59 years old, they're still having periods.
Yeah.
Something's not right. So it triggers me to do some more testing, to more evaluation, to make sure that they don't have cancer.
Right,
Is
right,
it
yeah.
true they've still got some production, which would be not unheard of, but odd.
Right.
So that's just a red flag to me
Roll out,
to do more
man. Yep.
evaluation. The infertility and nulliparty, yeah, that's one that you would want to consider. Obesity, I can't tell you how obesity just affects so many systems, but particularly the uterus. Yeah. Diabetes, and then ovarian cancer. And we do still see ovarian cancer, but certainly not as often as we do the endometrial cancer. But that might be your signal that that's what's going on. So they can go hand in hand. Most frequently in postmenopausal women, and that's the truth. And I've said over 60, you need to be and I start telling my women at menopause, okay, you have been a year without your period, you are in menopause. Please let me know if there is any vaginal bleeding spotting surprise. Oh, I'll tell you a spot. Well, not everybody does, because
Mhm.
I will oftentimes women come in, may not even mention it, and I'm doing their exam, and it's like, you're bleeding. How long, when did you stop your period? Well, I meant to talk to you about that. It's like, why didn't you ask me? So you need to ask your patients, make sure you educate them that if you have any kind of postmenopausal bleeding, let me know the first thing. Be in my office.
Yeah, make a phone
Yeah,
call,
yeah.
call me. Yeah, and I know that it says the DNC gold standard for
Mhm.
assessing uterine bleeding. I know you wanted to really touch base on this.
So we, the first, before I ever refer for a DNC, and as a nurse practitioner, I can't do that, but certainly our gynecologists can, and they do a lot of DNCs for various reasons. But the first thing that I'm going to do with any kind of abnormal bleeding or postmenopausal bleeding is I'm going to get that endometrial biopsy. Whether it is positive or negative, you're going to refer. Because if they're bleeding and it's negative or benign, more than likely our gynecologists are going to do a DNC, but it's a deeper scraping of the endometrium, and that's sent for biopsy. So even though we've had in the past where it's on a rare occasion, but even though we've had a benign endometrial biopsy, it has been found that there's some endometrial cancers found on the DNC.
Wow.
So they biopsy. So that's why that's the gold standard. It's going a little deeper.
Right.
But if there is endometrial cancer noted on your biopsy, your endometrial biopsy, once it's known cancer, that's usually you're going to refer out to a gynecologist, oncologist. And there's nobody in Hickory, but they're usually at Baptist or Charlotte or Asheville. We do have a oncologist, gynecologist that comes to Hickory a couple of times a month from Baptist for the Hickory women. So he will see, but he is not doing any kind of treatment, surgical treatment here in Hickory. He does his
Where
at
he's from.
Baptist. Yeah.
Where he's from, it goes
Yeah,
back.
exactly.
All right.
Hysteroscopy, that's something that's often done in our office. They actually do a hysteroscopy, which is a scope up inside the uterine cavity before they ever do a DNC. So they're looking as surgeons, they're looking up inside. So that's what that means. So usually if I'm referring for abnormal bleeding, I will tell the surgeon, this is what I'm doing it for. This is why I'm referring for a possible hysteroscopy DNC. I'm not going to tell her what to do.
Yeah,
but it's a possible.
Next steps are.
I am considering that's what you're going to consider.
Yeah.
CA 125, we usually, I've not done this on a routine basis. Maybe some of the gynecologists do, but regardless of what that is, if I'm going to do it based on my biopsy and what I see.
Okay. All right. So it says decreased incidents have been seen with combined oral contraceptives.
So that's one of the benefits when you're talking to your women about birth control pills or combined COCs, combined oral contraceptives. There's a lot of benefits to taking birth control pills, and endometrial cancer prevention is one of those. So a woman who has taken 10 years or more of combined pills, she's protected pretty much against endometrial cancer.
Wow. That's great. And there's physical activity, because we've talked about obesity so much and that being such a big risk factor, that physical activity is a big deal. Of course, low fat diet and other risk factors.
Yeah.
Treatment options: hysterectomy, radiation therapy, chemotherapy, and hormonal therapy.
And this is mostly done outside this area, but you will have those patients come back to you after their treatment's done. Yeah.
So most recurrence is found within 3 years. So
and even with endometrial cancer and they have a hysterectomy, most of the time we're watching a vaginal pap for at least 3 years afterwards. Sometimes that's done there and they may do them every 6 months for a while, and then it goes to a year, but oftentimes they are watching the endometrial cancers in that way.
Okay. So ovarian cancer. So highest mortality rate of
Yeah.
all gynecological cancers.
This is very disheartening. When your patient ends up with ovarian cancer, it's the fifth leading cancer, female cancer, but it is oftentimes hard to find. So if women are coming in with bloating, something's not right, and bloating, I can get a ultrasound covered with bloating. So to put them at ease, even though that may not be what's going on, an ultrasound would be one of those things that I do to look for cancer. Oftentimes when we're doing a bimanual exam, if you can feel a pelvic mass, but it's difficult and it takes practice, and it's oftentimes missed because women carry a lot of weight. We have very few that are really thin that you can actually feel a mass, but sometimes we can, and sometimes when it's firm enough or large enough where we can feel it, sometimes at that point it's too late at that point. So but that's why the prognosis is poor if we can catch it in early stages. So I had a patient that I was just like, oh my gosh. We did an ultrasound for something else, an incidental finding. And my sharp doctor who reads my ultrasounds, something did not look right of an ovarian mass that was found. And this wasn't even why we sent her for the ultrasound, but something did not look right. And she had stage 1 ovarian cancer. We found it so early.
Wow.
Yeah. So once I found this, the doctor that read it, she said something doesn't look right here. I would send her to a gynecologist and send her off soon. And of course, we did some blood tests, and we'll talk about that. But we did save her.
Wow.
That's one of the
An
first that we
incidental, y'all.
found.
That's a real good
Incidental
find. Yep.
finding. So yeah.
That was a good find for sure. Risk factors. So, there's that family history in the first degree relative.
BRCA 1 or BRCA 2. And, this first degree family history, you can get your genetic counseling testing covered with a first degree ovarian cancer family member.
Yep.
So, yeah.
There it is.
Even on a Medicare, I had that covered a couple of weeks ago. Even on a Medicare oftentimes won't cover genetic testing unless they've had cancer themselves. But it did cover that one. She had just regular North Carolina Medicare. It did cover that with a first degree relative. So,
wow.
Yeah.
Unreal.
Yeah.
All right.
So with trying to find out if they have ovarian cancer, abdominal bloating, there it is, abdominal bloating and discomfort. They get full quickly. If they have they can't eat as much as they want to. It's just like, oh, what's wrong with me? I'm just not able to eat as much as I used to, and I just feel full. Indigestion. That's a good reason to do a pelvic ultrasound. And then if you find a mass, then you're going to do some blood tests. CA-125 is our standard. Now, there is a reason why we don't do screening CA-125s, because we can get false positives if they have endometriosis, if they have uterine fibroids. How many women have uterine fibroids? A lot of women. And so many times CA-125s, even insurances won't cover unless we just go to bat for them. But that's your basic test, and that's a cancer marker, or ovarian or uterine. But we have some more extensive tests that are a little more expensive, but a little more specific. The ROMA test, and I really can't tell you what ROMA stands for. I'm sorry,
Mhm.
but the Raman test is more expensive, more specific, and it tests for the cancer cells in the premenopause versus the postmenopause. So it gives you a couple of different readings, including that CA-125. So that's more helpful when you are referring out to that provider, the oncology.
I can't see that it
provider.
breaks down what ROMA stands for, honestly, but that's
And
what I was sitting here trying to Google.
that's about, in my experience, about $500 the insurance won't cover. So I'm always upfront about the patient, but many times she's like, whatever it takes, let's
Yeah.
just find it out. We're also doing I did this on a patient that I was suspecting, because she was an older woman and had a family history of ovarian cancer. I'd already done her ultrasound. She had a very small, solid ovarian mass, and we weren't sure the significance because it was so small. And it was a test called the OVA1, and hers was negative, but that's another testing source that's out there that you can do.
So there's your standard surgical procedures. So whether it be a total abdominal hysterectomy, bilateral sapingo, or
oophorectomy. We call it BSO.
That's it, BSO. It's so much easier to say. But
Yeah.
whenever you're a nurse, if y'all remember and having to write all that stuff out when they won't let you abbreviate, and you're like, I have no idea how to spell this. Yeah, that was like the worst. So there's a bunch of stuff that we can actually do.
And so, your gynecology oncologists are going to do extensive surgery. Some even do, I've got my favorites that I refer out. So, I keep my list of, and when I tell a patient, where do you want me to send you? We start with, well, where do you think? I thought, well, I've got good resources, but whatever's going to be good for you and your family to go to. So, I've got those in Charlotte. I've got some great doctors in Charlotte that I'd be happy to share with you, but they do, it depends on what, everything is changing and is different, but they will get into the lymph nodes, and that's how they're ended up staging the cancers, by doing that extensive surgery and washings. And but we've got some good resources for most of our major cities if you ever need that.
That's great. All righty. Pick out my next recording. So we're going to chapter 17. Gotta find it. Hang on. Not that one. Not that one. I got 500 screens up. That's how I work. Here we go. All right. So breast conditions. Nostalgia, which is breast pain. It says it's benign in 90% of the cases, of course, and most have been found to be more cyclic, right?
Well, and I love this part where it says common breast concern. Guarantee it. That will bring somebody in quicker than anything is the breast or pain, and it may have been hurting for several weeks or a day.
Yeah, or a day.
And so it does scare women to come in to see you. So
100%.
Yeah. So.
And of course, that fibrocystic breast changes are common among people who have that breast pain. And I'm sure we're going to talk about that.
Yeah, and I like how they say fibrocystic breast changes. It is not a disease, but you will see some still radiologists call it breast disease, and it's not a disease. It doesn't kill us. But
no,
it's very common amongst a lot of women, that type of tissue.
There's also non-cyclic nostalgia, unilateral, local pain, sharp burning. That's what women would normally describe it as. Those are in your women age 40 and older.
Yeah. So we commonly see that as well.
History is so important. Would you agree with that?
Oh, absolutely. And if there's any risk for pregnancy, even though they don't think they can get pregnant after 40 for some odd reason, that's important, because that's one of the first things that the pregnancy will do to a body is it causes breast pain.
Yes, ma'am. It sure does.
And rarely is a sign of breast cancer. You still need to consider that, but most of the time it's not going to be breast cancer. But convincing your patient that it's not breast cancer is another story.
Absolutely. Absolutely.
Yeah.
So there it is.
No reassurance.
See, I'm telling you, she looks at the PowerPoint slides. Just saying.
Yeah, reassurance. And
Absolutely.
yeah, so the non-pharmacological, complementary, and the alternative. So we all got the ones that we have gotten used to saying, but my biggest thing is caffeine. Now, caffeine we all, I'm a fan too, but when we have women who, when you find out how much caffeine they drink, and students are sometimes the worst.
Amen to that. Can everybody vouch for that? Yes.
Well, as a student, I remember thinking,
Yes.
golly, but I drank a lot of Cokes during that time and coffee, but women who drink it constantly throughout their day, they have fibrocystic breast changes upon that. They are real prone to having breast pain, and they're in your office. So the first thing I'll say, let's look at and see how much caffeine you're drinking. Not telling you to cut it all out. That might take away your breast pain if you did.
Yeah.
However, I need you to cut down on it, and cut down quite a bit so that you can see improvement. That makes it. Is it going to hurt you to continue with that caffeine? No, not as far as your breast, but it will cause breast pain. So oftentimes we're saying, sometimes a patient just needs to know what to do to help relieve the breast pain. Good supportive bra. Most women are not wearing the correct fit of a bra. And so before COVID, I used to send women to, well, you might want to go check out Belk or Dillard's. They have certified bra fitters. But even in Primrose Oil, you can have them take the gel caps a couple of times a day. That sometimes can help with relieving the breast pain. We used to use vitamin E, 400 IUs. I do in some cases for short term, because you can still get vitamin E. And I was like, okay, take this for about a month, 6 weeks, and see if it does help your breast pain, and then stop it.
Yeah.
That's just in my own practice that I do that. They can take topical NSAIDs. That's a good idea. I haven't thought about that. Well, now we've got the topical Aleve.
Yeah.
And certainly that's not going to hurt anything. Or I'll tell them take Tylenol, ibuprofen, or Aleve that they can
But if it's
use.
hurting them bad enough, they're going to listen to you and try to make a change.
And then the herbal products, just like with the
100%.
Evening Primrose. We've used that for a lot of years. It's not going to certainly hurt them, and it might help in some cases.
Right. So of course, surgery is rarely indicated because it's usually benign.
I've never referred anybody for surgery because of that. So.
And of course, she's already said it. It's really common during pregnancy and even lactation. So that makes sense. So let's talk about nipple discharge. And I know you've kind of seen this throughout your practice, and we've kind of talked about it. There's that normal lactation. You have galactorrhea, unrelated to childbearing, so they can actually.
Well, so I can have a patient that may have a 15-year-old, and she has some spontaneous breast nipple discharge, but it's happened periodically since she breastfed. Certainly that can be proven that it's okay, but you got to prove that. Got to prove that.
There's your non-milky discharge, unilateral. That's kind of a big thing, right? From single duct, clear blood in color, and that's more likely associated with cancer. Yeah. So the spontaneous, that's the word that kind of says, okay, we need to check this out. When they, now sometimes it can happen, but whenever their bra is wet or they notice that dry discharge on them,
it's worth checking out. Because in some cases there can be a mass related to that.
Yep.
Usually result by benign process, but malignancy also should be considered.
100%. You just said it. It's so funny. All right.
So some of these on the next slide, the 2 or 4, yeah, some of these like the intraductal papilloma, we do see that on mammograms. And oftentimes they've already been biopsied at that point to get that particular diagnosis. So, you know, with the nipple discharge, I am gonna, well, I might be skipping ahead.
Oh, nipple discharge by mass or cancer.
Yeah,
Is that
yeah.
what
So,
you're-
you know, you're gonna, in part of your evaluation, you're gonna do a breast exam. You're gonna look, you know, do your normal breast exam.
There it
You're gonna
is.
look for any differences in the breast. You're gonna check one breast, and you're going to go ahead and check the other breast to see, is it a unilateral change? You're gonna look at that discharge if you can get some out. Oftentimes when I'm squeezing the milk ducts and you can find the discharge, you got your disposable towel there, you can see what color it is. But then also reviewing medications, and I can't tell you the ones right off the top of my head, but there are some medications that will cause discharge. Some of the psych medications that we use can cause a discharge, yeah. But and then hypothyroidism, yeah, that's something to consider as part of your diagnosis as well. But with evaluation, you're going to get a mammogram. Whether it's a unilateral, you know, this is my fault. If you've got a patient that comes in, she's over 40, she hadn't had a mammogram in a while, you want to go ahead and do a diagnostic bilateral, get both of those breasts while you're there. But if she's recently had a mammogram, say 6 months ago, and she's in your office and she's got nipple discharge, you still want to get a mammogram, a unilateral diagnostic mammogram,
Yes.
so
yes.
that you can thoroughly evaluate that.
Right.
Yeah.
So I think we've kind of done all that. Benign malignancy.
And I'm not going to make that decision to biopsy. The radiologist is going to make that determination.
Oh, yeah.
Yeah, so I don't have to worry about that. So with this slide, you know, most mass is benign, malignancy must be considered. So that's what by doing your mammogram, that's where you're going to find that. So some of the things that are not going to cause cancer, the fibroadenomas, we see those all the time. And patients will know, oh, I've got a mass over here. Hadn't changed any, but I'll tell you where it is. I'll say, wait a minute, let me see if I can find it. But it's usually a fibroadenoma, a solid mass that you can feel. And cysts are not worrisome. You'll feel the lipomas. They will find those on the mammograms. Yeah. So and even the fat necrosis, hematomas don't see that very much unless they've been in an accident. But I can't tell you that I've seen the phylloid tumors, maybe, but what was it I saw over here? I've seen on mammograms was the intraductal papilloma.
Oh yeah.
Yeah. So once you release them to the radiologist, you got them set up for their diagnostic. I tell women this is different than a screening mammogram. You've got something that you're trying to figure out. So this is called a diagnostic. So they're going to ask you, well, is my insurance cover it? It's not going to be covered free like a screening mammogram is, because it is diagnostic.
Right.
But you have to order it that way. That just gives the radiologist permission to get all the views that he or she needs to get, including an ultrasound for further evaluation. And at that point, they make an appointment for your patient to go in and all the area, Fry, Catawba, Blue Ridge, all of them are set up to do these diagnostic mammograms wherever you may be, wherever your patient wants to go. And they will schedule it on a day that a radiologist is there. They schedule more time, so they have, patient may be there 2 or 3 hours getting these done, particularly if there's extensive changes. And then oftentimes they'll use a nurse navigator, and the radiologist will tell the nurse navigator, and the nurse navigator being the liaison between the radiologist and the patient. But they're setting, if there's a need for biopsy, they're setting this biopsy up many times, whether it's the tomosynthesis guided, which is 3D mammogram, if that's a guided biopsy is recommended. Sometimes stereotactic biopsy. I don't know the difference, but apparently the radiologist knows the differences that they need in order to do these biopsies. Even the MRI assisted MRI assisted biopsy has been done before, so they kind of take over.
Right.
And then once you get the results back, patient already knows the results and what needs to be done.
Right.
So, which is kind of cool.
Oh yeah, absolutely.
Takes the heat off of you.
Exactly. And I think we kind of went over the rest of that with that. You're doing such a great job. So likelihood of malignancy increases with age. Second leading cause of cancer deaths in women. We kind of should all kind of know that.
Yeah, exactly. And the 1 in 8, that is true. That's the statistics that I use for women. But it's interesting that starts at age 50. Is 1 in 8 women are diagnosed with breast cancer. By the time that they're 90, it's 1 in 6. So that's where I use that a lot. And when I'm talking with a patient, when they ask me, I don't know if this is in here, when they ask me about a thermogram, I try to sway them not to, please don't do that. That has not been proven to find cancer, but many times they're so worried about radiation that they're getting with the annual mammograms. That is more specific, doing a mammogram, and particularly the 3D mammogram. So I'm encouraging them, please get your mammograms. You can't do anything else for yourself. Do a mammogram every year after,
so important,
particularly after 50.
So important.
Yeah.
Alrighty. So we've talked about the mammogram. There's your different types of breast cancer. And of course, look for symptoms of potential metastasis, right? And there's kind of all that, what involvement we're talking about.
Well, I wish I had a picture. I had a lady about a year ago who came in to me. She was seen by a well-known doctor that was treating her. He's a specialist and probably should have been encouraging her to get other treatment by other physicians. But anyway, she tells him about, she had some nipple discharge, some pain, and he said, well, you haven't been getting your mammogram. She's in her late 60s maybe. So anyway, she comes into me and she has the orange peel skin. When it's to that point, you know that it's already spread. Yeah, it's such a shame because we could have caught it so much earlier. So I think it's been a year since I've seen her one time, and that's just to see her for this mass that she has, these changes that she has. And I'm upfront and honest with her. And I said, I'm going to tell you, I don't think this is going to be a good turnout. I don't think this is going to be benign at all. We've got to get you started. But it won't surprise me if you don't have cancer. And I never tell a patient that ever.
Right.
But I knew by the base what I saw that it was to that point. So she was not surprised at the time of her mammogram. And so they took her from the radiologist and got her into the appropriate treatment.
Right.
And so she's been seeing an oncologist. She's already had to have some chemotherapy, I think, before they can ever do surgery on her. Yeah, so she is already to that stage where she's got to have treatment before surgery.
Wow.
So,
Wow. That's pitiful, you
Yeah.
know.
Yeah.
There it is. We all know we should do a really, really thorough, comprehensive breast exam.
Yeah.
Like that is so important.
And I've worked with some students that just barely do, and the patient don't feel good about it either. So I make a point when I'm standing there with the student, this nursing students, whatever, but like do a thorough. They want to know that you're feeling everything, and because they don't know how to do it, or they don't feel sure of themselves when they do their self breast exams.
Right. It's so important. There's that skin change. Always look at the skin, like she said, with that orange peel. We all kind of have heard of that. I know papillomastosis, nipple discharge. There's your diagnostic test, possibly even tissue sampling.
So if you
biopsy.
feel something, whether you think it's a thickening or you're not sure, and you just don't know what to tell the patient, it's not gonna hurt to do a diagnostic. And even if you send her and it's just normal changes of the breast, so what?
I
You
mean,
know,
that doesn't hurt anything.
I'm first to admit, I don't know what's underneath there, but
Yeah.
you know, I'm glad that she went and got checked.
Yeah, 100%. So there's the TNM system, which does the size of tumor, the lymph node involvement, metastasis.
Yeah.
You know.
That's just how you get your report
Right.
once they've already seen the surgeon,
Right.
actually. So
treatment, there it is.
and it is so widespread. There's so many different
Depends, right?
Right. It depends. And there's so many. I have learned just being on this side of it, there's different treatments for different cancers. And so, you know, get them either to a good surgeon, or you know, and then they usually are referring to the oncologist,
Yes.
wherever that might be.
Right.
So,
Right. You can do a breast conserving surgery where they just take out, you know, the cancer itself, not necessarily the entire breast, right?
yeah, and then the radiation therapy,
Exactly.
that's commonly done, and some cancers don't require radiation, but some do. So, but I've just heard nothing but great things about this practice in this area that does radiation therapy. Everybody who has had cancer, who's been there, they smile whenever they
Wow.
talk about their caregivers.
Must be pretty,
yeah,
pretty
pretty
great
awesome.
place, right?
Yeah.
So there's the tamoxifen. We've kind of talked about that.
Well, that says 10 years. And I think it depends on the type of cancer and the type of the doctor's preference. I've seen 5, but I hadn't seen too much 10, but whatever. It's on the oncologist and what they do. But yeah, just be on the lookout of the risk of taking tamoxifen. And they also use letrozole. Whether they're using several oral chemotherapies after they've been treated to prevent the recurrence of the breast cancer.
Right.
And most of the time, I don't see too many times where the oncologist releases a patient after she's considered cured. After 10 years, it's a milestone. After 5 years, it's a milestone for those patients.
Right.
After 10 years, it's a milestone. But many times the oncologists are dependent on us to also check that patient as well. Now you're still seeing your gynecologist and, you know, follow up there. So
yeah, 100%. All righty. All right. So Terry wanted to really kind of hone in on this genetic testing for you guys because it is something that we're seeing far more than when we have in the past, honestly. And I think it really opened my brain a little bit. Like I remember going to clinical and they were asking patients about it, but I never got to see the other side of it. So she's going to kind of hit this a little bit so you guys are aware of options for patients in regards to genetic testing.
So in our office, now it's just usually the new patients or maybe possibly patients that we've been seeing, but maybe we've misgiven this or doing this screening on them. So when you have a patient with a strong family history, when I mean strong family history, there's at least one first degree or second degree family member, maybe on both sides. It doesn't matter anymore. If there is a family member, evaluate that, go dig deeper in their history. So I asked them to fill this out, and it is a very confusing form. This is specifically from Myriad, that works with our practice, because we're the first screening. And then once I've got a patient who fits that picture, so in other words, say, well, like I said before, the ovarian cancer in your family at any age. Up at the top, it says either you, your mother, father, brother, sister. So anybody in the family, it goes even further to great grandmother, great aunt. If there is anybody, a lot of times Myriad can get this paid for by their insurance. This is wild because I do not see men in my clinic. Prostate cancer at any age. I've had a few women who they may have had a dad, a grandfather, and it needs to be on the same side of the family. So let's say dad, paternal grandfather, or paternal uncle, first cousin who may have had prostate cancer. Guess what? They are qualified to get a test done.
Wow.
So on their assessment and plan, I've got family history of prostate cancer and this genetic test ordered. So that's been
and male breast cancer. You know, we talked about that too, because it can happen.
That sends shivers up my spine when I have a patient who has a male person in their family with male cancer, breast cancer, because they are so at risk at that point. That's an automatic. Yep. That is an automatic.
I've taken care of patients that have a history of breast cancer.
Yeah. So, well, and then the triple negative.
Yeah.
Meanest cancer alive is a triple negative breast cancer. That means that the estrogen receptor is negative, the progesterone receptor is negative, and the HER2 negative. When they are negative for all, you'd think that would be the best case scenario, but it's actually the worst case scenario. It's a very aggressive cancer. Wow. So if there is anybody in either side of the family, grandmother, aunt, it doesn't matter if it's paternal or maternal.
Wow.
They qualify. Then on this form, they do include colorectal cancer, but a lot of these cancers, if it was before the age of 50, and they're confused because they go, well, yeah, I had a grandmother. She might have been 55 whenever she was diagnosed with a cancer. I was like, well, that doesn't qualify you to get this. We know that that's in your family history, but it doesn't qualify you for genetic testing. But the before 50 is significant. So this group of tests, like I said, it not only includes the breast, ovarian, pancreatic, prostate, but it also includes the colon and the uterine cancer. But so once I see the patient, I've talked to her about, she qualifies. What does this involve? She asked me, what does this involve? Will this change my insurance? It's like, no, will insurance pay for it? Well, at this step, I don't know that. But what we do is we try to educate you on what this test means, draw the blood. We actually take them to a room with a phone and give them an 800 number so they can talk to an actual genetic counselor over the phone. She gets additional information. I tell the patient basically so they can go to bat for them to get this covered by their insurance. And then we send this all to Myriad. We give them an appointment to come back and see me in 6 weeks. That's about enough time for Myriad to get the blood sample, to check their insurance, to run the test. Now, I reassure patient, if your insurance does not cover it, or if there's any cost to them over $1, Myriad representative is going to call them. They will not run that test without their permission.
Wow.
If they know that there's going to be a cost. So anyway, when they, because oftentimes the insurance says, well, but there's some kind of clause or law that says insurances have to cover these who are at high risk.
Wow. So
they're getting a lot of these tests paid for. So when I get their test results, it comes in FedEx folder. It's big high tech. And I tell the patient, well, why do I have to come back and get the results? I just tell them it would be cruel for me to send them the results because they'll look at it and not know what to do with them. So when I get their results, I was intimidated at first. However, we do have genetic counselors available to us that we can have our questions answered before we ever counsel the patient. So it's basically, I go through those test results. Most are negative. My heart drops when it's positive, but there's negative, positive, and then there's a lot in between. And what I mean by that is they're negative, but there are some recommendations made. So they particularly on the breast score, there is calculations of the patient. I'm not certain what goes in these calculations: age, race, family history, and then they always put the entity of they're going to live to age 85. And there may be some other factors that are put into these calculations, but their risk is calculated for a 5-year and a lifetime. And if their risk comes up to be more than 20% on the threshold, then recommendations are made, such as, and it might be 20.1%.
Right.
Those
Right.
recommendations are made, but it could be breast awareness. So in other words, breast self-exam, clinical breast exam, you or me checking their breast every 6 to 12 months, annual mammogram tomosynthesis, 3D mammogram, get that annually, or an annual breast MRI with and without contrast. Then there's some guidelines of when we start this, because if you've got a 20-year-old and she's at high risk, we may not start screening mammograms until she's 30 or older. So there's specific recommendations of these made on these results that we're getting. So I go through these step by step with the patient. I try to answer their questions. I tell them their risk. And then those that are positive for whatever gene it is, usually if it's positive for BRCA, for Lynch, for CHEK2 is one that I commonly get. Then I am referring to somebody that can watch them more extensively, particularly those genes that puts them at risk of more than one cancer.
Absolutely.
So if it's breast and ovarian, I'm referring out. If it's colon and uterine, or whatever the case
Right,
may be,
right.
I may be referring to Levine in Charlotte. They don't call it Levine anymore, but Levine and Charlotte, for them to be under a multidisciplinary approach to where they're watched with colonoscopies, they're seen by the breast cancer experts in their field who may watch them a little closer than what I can
So
do.
I call this definitely proactive.
Very proactive. So when a patient says, should I have this or not? I'm just like, yes, let
Why
me.
not?
Well, because so many are afraid
I know.
that
I
it's
know.
going to be, and what I'll tell them when we get a surprise and it's a positive gene, I'll say, please don't look this as a black cloud over you. We've looked at it as we've caught this before you develop cancer.
Right.
You may not ever develop cancer, but if you do, we are being proactive in
Right.
catching this before it ever happens to you.
That's the beauty of stuff like this, like the cancers versus those like ALS,
Mhm.
who,
Yep,
that there's
yep.
not, what I'm
Yeah.
saying? So
The
to me,
leukemias,
right,
everything.
right.
And I'm certain that there's going to be more and more genetic testing
Right.
done on these other cancers.
Right.
I'd love something to be done for heart disease, because
Me
that kills more
too.
people than cancers do.
Right.
But our patients are more concerned and more scared of the
I can
risk of
understand
cancer.
that. I can
Yeah.
understand that. But I can see it in the beauty of it too.
And back to our Lynch
let's
syndrome,
go down.
colorectal, uterine, endometrial, ovarian, gastric, stomach, pancreatic, ureter, bladder, and brain. Oh my gosh, so one person can't follow this.
Right. 100% multidisciplinary for sure. I love it. All right, well, we appreciate you sharing this with us because it helps broaden our views as APPs. So this ends this week's lectures, and I know that this is kind of lengthy, and I apologize, but you can stop and go anytime that you want to. And I look forward to seeing you guys next week. Take care.